Morning. My name is Zlatko Szukovsky and I am from Ipswich in the United Kingdom. And one of my talks today is about intravenous anesthetics. It is a fairly limited time to discuss all the intricacies of the intravenous anesthetics agents in this talk. And it is mainly designed to give you a good systematic overview and help to prepare the structure of answering these kind of questions for the exam. The intricate details you can find in standard anesthetic textbooks, and you all know what the better ones are. So what are we going to talk about then? We're going to talk about some definitions, and definitions are very important because if you produce a definition, it immediately allows an examiner to know that you have a pretty good idea what you're talking about. We talk about ideal anesthetic. We'll briefly touch on mechanisms of actions of some common intravenous anesthetic agents, and we'll look at some core drugs. So definition. So intravenous anesthetics agents, they're agents which will produce loss of consciousness in 1 arm brain circulation time. And an average person, it usually takes about 30 to 45 seconds for your intravenous injection to reach the brain. It obviously depends on the cardiac output. The very notable exception of is ketamine, but you will know that ketamine is quite an exceptional drug. So ideal anesthetic agents, ideal intravenous anesthetic agents more precisely. We want them to start acting pretty rapidly. We don't want to wait ages and ages for them to work. And for that, they need to be unionized at physiological pH. We want them to be lipid soluble, and that's because they work in the brain, and brain is mostly consist of lipids. We want them to produce rapid recovery for obvious reasons. It would be brilliant if all anesthetic agents have some analgesic properties, but you will know that they don't. They should produce minimal cardiovascular and respiratory depression. They should be water soluble to facilitate production and administration. They should have long shelf life, so you don't have to throw them away unnecessarily. And they should be safe if administered intra-arterially. And that's just a safety mechanism. So ideal intravenous anesthetic agents should not possess certain qualities. They shouldn't produce post-operative nausea and vomiting. They shouldn't produce pain on injections. Again, ideally, there should be no excitation, no emergence phenomena. And they shouldn't interact to any great deal with other agents. They also should be non-toxic. So as you know from the previous slide, we are a little way away from obtaining an ideal anesthetic agents. Some come really close, but probably there is still a room for one more discovery. Let's talk about some mechanisms of action of the anesthetic agents. So, while I was researching for this talk, I found a wonderful quote. So you can read it on the screen, but it says, "The practice of anesthesiology currently does not require a knowledge of general anesthetic pharmacodynamics, whether the anesthetics produce their effects by disordering lipid or modulating GABA-A receptors doesn't affect clinical decisions, or at least not for the foreseeable future." And that was printed 20 years ago. To a degree, it's probably still the case. Having said that, it is interesting but largely immaterial because we all as doctors are a bit of scientists, and we want to know what to do and how things work. So it's impossible to talk about the mechanisms of actions of anesthetic agents without mentioning Meyer and Overton, and you will be all familiar with their hypothesis. Although the most famous one in the history of anesthetic agents, it is not the only one that's been produced. As you can see from this table, from 1847, scientists were troubling themselves with the questions of how anesthetics work, and they produced all sorts of theories. See, I'm not going to mention them all. And even more recently, things like that were produced. The current thinking, however, is brought about. It was brought about in 1984 when Franks and Lee demonstrated that most general anesthetics inhibit the lipid-free enzyme 5-fly luciferase. And the key is here is it's lipid-free. So since then, the current thinking is that most anesthetic agents work on proteins within receptors, and they produce significant effects on ligand-gated ion channels, in particular GABA-A receptors, and also on other proteins responsible for neural activity, such as 2-pore domain potassium channels. Continuing with mechanisms of actions, beta-3 subunit of the GABA receptors reduces the sensitivity of mice to the IV anesthetic etomidate, but not to inhaled anesthetics. Modulation of GABA receptors alone accounts incompletely for the mechanisms of actions of anesthetics. NMDA receptors play also an important role, particularly for some intravenous anesthetic drugs. It's important to remember that NMDA receptors are in nature excitatory as opposed to GABA-A receptors. So the anesthetic agents decrease the firing of these receptors. So GABA-A receptors are ligand-gated ion channels consisting of 5 subunits arranged around the central pore. There are a number of other forms of GABA-A receptors, and they determine their agonistic affinity, probability of ion channel opening, and conductance. There are 6 subtypes of alpha subunits, 3 subtypes of beta subunits and gamma subunits, and also delta, epsilon, and theta subunits. The most common combination in mammalian brain being a pentamer consisting of 2 alpha, 2 beta, and a gamma subunit. And I've got a wonderful picture here to look at, and this 3-dimensional structure of the GABA-A receptor. So they form a chloride channel, and they have molecular targets for barbiturates, IV anesthetics, propofol, intimidate, and volatile inhalation anesthetic agents. Activation leads to postsynaptic hyperpolarization of membrane, inhibitory postsynaptic currents, and ultimately inhibition of neuronal activity. There are some important additional mechanisms apart from GABA-A channels. So we briefly touch on 2-pore domain potassium channels, extrasynaptic receptors, and integrated neuronal networks. So 2-pore domain potassium channels, they are a family of 15 potassium ion channels, and they importantly characterized by voltage independence and absence of being activated by an action potential, which is in direct contrast with standard ATP-dependent potassium channels, which are sequentially activated and inactivated by area action potentials. These special potassium channels are responsible for leak currents, determining the resting membrane potential. They are widely distributed within the central nervous system, and they are modulated by most inhaled anesthetic agents. They're present pre and postsynaptically, and some anesthetic action is explained by presynaptic inhibition of excitatory neurotransmitter release, but also by competitive inhibition at postsynaptic ion channel receptor sites. Extrasynaptic receptors, they include alpha-5 and delta subunit containing GABA receptors, and they're expressed mainly in hippocampus, where their activation inhibits long-term potentiation and hence memory and learning. While the alpha receptors, while the alpha-5 receptors have been shown not to be involved in causing sedation or immobility, some extrasynaptic receptors are preferentially potentiated by intravenous anesthetics. Integrated neural network models are complex and interesting. It has always been very difficult to link the effect of anesthetic at particular ion channel to its actual behavioral effects. And that's when the neural networks model was developed, and essentially it says that disruption of neural networks involved in sleep and arousal could be the targets for action for anesthetic agents. And particular areas of interest are ventrolateral preoptic area of hypothalamus, also tubermammary nucleus, and ascending reticular activating system. So let's talk about core agents now. And it's important to try and stick with the same structure when answering questions, particularly in the exam situations. And the questions about intravenous anesthetic agents are pretty standard in the exam. So we'll talk about presentation, we'll talk about uses, we'll talk about effects on pharmacodynamic, we'll briefly touch on pharmacokinetics, and we'll mention toxicity and contraindications. And we'll start with thiapentin, also known as thiapentin or pentothal, which is certainly here in the UK is disappearing quite rapidly, and younger generations of trainees are not hugely familiar with this drug, certainly not from the clinical perspective. So the molecular structure of thiapentin is based upon the barbiturate ring, and here is a picture. You'll be pleased to know that you need to draw this picture only for extra points. It's not required to draw a molecular formula for thiapentin or any other intravenous anesthetic agents for the exam purposes, unless you really want to. It's applied as a hygroscopic pale yellow powder, and hygroscopic means that it tracks moisture from atmosphere if exposed to atmosphere. That is why it's packed in the inert atmosphere of nitrogen, so not to attract any moisture. And the ampoules commonly contain 500 milligrams with 6% of sodium carbonate. It's reconstituted with 20 ml of water that yields 2.5% solution, 25 milligrams per ml, with a pH of 10.8. So highly alkalotic solution. And the alkaline solution is bacteriostatic and can be kept safe for up to 48 hours without risking bacterial growth. So uses, the main uses for thiapentin, induction and status epilepticus. And I think it's fair to say the use of thiapentin has decreased very, very considerably in the last decade or two. So a dose of 4 to 5 milligrams per kilogram of thiapentin produces a smooth onset of hypnosis with good definitive endpoint within about 30 to 45 seconds of intravenous injections. It has to be noted that thiapentin is probably the intravenous anesthetic agents with the quickest onset of action. Also, recovery from a single dose is rapid due to redistribution, and there is a low incidence of restlessness and nausea and vomiting. So far, so good. However, it directly depresses the contractile force of the heart, reduces cardiac output and blood pressure. There may be a compensatory increase in heart rate. It decreases the venous tone, causing pooling of blood in the peripheral veins. It significantly increases the degree of hypertension, particularly in patients who are hypovolemic, for example, following a hemorrhage. And the famous story goes that more soldiers were killed by thiapentan during Pearl Harbor than by Japanese planes, because it was first anesthetic, which was widely used in with mass casualties. It has been questioned whether or not it's true, and whether or not it was due to the using thiapentan on patients who were bleeding, or was just poor airway management at the time. But either way, that's the world famous story about thiapentan. So respiratory depression is common, and period of apnea is usually seen following a bolus dose. Airway reflexes are well preserved in comparison with propofol, and histamine release can occur, which may precipitate bronchospasm. So because airway reflexes are very well preserved, it's not the best anesthetic agent to use if you're planning to use a supraglottic airway device. Thiapentan also reduces cerebral blood flow, cerebral metabolic rate, and oxygen demand. It has potent anticonvulsant properties. Infusion of thiapentan to produce a barbiturate coma lowers intracranial pressure and may improve neurological outcome. However, it is associated with significant accumulation, causing a very prolonged effect and multiple complications. Say, it's not used to the same degree it used to be on neurointensive care units. Pharmacokinetics. The pK is 7.6, so 60% is unionized at pH 7.4. 65 to 80% have protein-bound in plasma, which means that only 12% is immediately available. Rapid action due to high lipid solubility and large proportion of cardiac output to the brain. Rapid emergence is due to rapid distribution of metabolism. Metabolism is slow and occurs in the liver. Excretion of metabolites occurs mainly in the urine. Following repeated doses of infusions of thiapentan, metabolism follows zero-order kinetics. And just to remind you, that means that a constant amount of drug is being eliminated per unit time, irrespective of the plasma concentration. Porphyrias, cannot mention porphyrias when talking about thiapentan, and they're a group of disease characterized by overproduction and excretion of porphyrins, intermediate compounds produced during hemoprotein synthesis. And the acute attacks may be precipitated by drug, stress, infection, alcohol, pregnancy, and starvation. Thiapentan may also precipitate porphyria due to hepatic enzyme induction in susceptible patients, and therefore should be avoided in porphyrias. So let's move on to etomidate. And that's another very interesting drug which has been going out of favor over the last decade or two. Again, the pretty picture of imidazole structure, and it's imidazole ester, and it's usually presented as a lipid emulsion or as a clear solution containing propylene glycol at a concentration of 2 mg per ml. Its uses, it's used for induction, and the standard induction dose is 0.3 mg per kilogram, and The induction of anesthesia can be accompanied by involuntary movements, which may be mistaken for generalized seizure activity. So as far as ideal anesthetic agents are concerned, this is something that we really do not want to see. Recovery is frequently unpleasant and accompanied by nausea and vomiting. Again, not ideal. Pain and injection is common, and there is a high rate of thrombophlebitis in the postoperative period. One might ask, why would we use it? And indeed, we don't use it that much, but the main reason we use it, or used to use it, is because it causes the least cardiovascular depression of all the IV anesthetic drugs. It causes small reduction in cardiac output and blood pressure, and in the past was widely used to induce anesthesia in the shocked, elderly, and cardiovascular compromised patients. As I mentioned, it has become significantly less popular. So respiratory effects, it causes transient apnea, it can cause cough or hiccups. Like thiopentone is not ideally suited to use with LMA because laryngeal reflexes are relatively preserved. Postoperative nausea and vomiting after etomidate are very common. Pharmacokinetics, 75% albumin bound. It is rapidly distributed and it's rapidly metabolized by hepatic and plasma esterases to yield inactive metabolites. Excretion is predominantly urinary, and elimination half-life varies from 1 to 5 hours. Etomidate inhibits 11-beta-hydroxylase, an enzyme important in adrenal steroid production. A single induction dose blocks the normal stress-induced increase in adrenal cortisol production for 4 to 8 hours and up to 24 hours in elderly and debilitated patients. Continuous infusion of etomidate with sedation in critically ill patients has been shown to increase mortality significantly. And as a result of that, its use in recent years has declined very considerably because of the perceived potential morbidity and possibly mortality risk. Ketamine. Not just one, but two pretty pictures, and the reason is, as usually, ketamine is presented as a racemic mixture. So it's a derivative of phencyclidine, which exhibits the hallucinogenic and neurotoxic effects. A dissociative drug is one which reduces signals to the conscious mind from other parts of the brain, typically the senses. And as I've just mentioned, it can take form of two stereoisomers, R and S-ketamine. They show a different 3D arrangement in space, making them non-superimposable, and they're universally referred as mirror images of each other. It's usually presented as a racemic mixture. However, S-ketamine is available in some countries and is 2 to 3 times more potent. The pH is 3.5 to 5.5, and it can come in various concentrations, 10, 50, or 100 milligrams per ml, and it contains preservatives which prevent intrathecal or epidural use. Again, in some country, you can obtain preservative-free ketamine. It is absolutely unique from the IV anesthetic agents, for many reasons, but one of the reasons that it can be administered intravenously, intramuscularly, orally, nasally, rectally, and the preservative-free solution epidurally. The dose is very much dependent on the route of administration and the desired therapeutic effect. For induction of anesthesia, a dose of 1 to 2 milligrams per kilogram intravenously or 4 to 10 milligrams intramuscularly. Significantly smaller doses of 0.2 to 0.5 milligram per kilograms IV are used for analgesia. The onset of action is slower than other induction drugs, and unconsciousness is used within 1 to 2 minutes after intravenous injections. However, the endpoint may be very difficult to judge, with patients keep staring in the distance for a short period of time. So you can't really necessarily tell whether or not they're asleep or not. The duration of action of single dose is approximately 5 to 10 minutes, and the ketamine is metabolized in the liver, and conjugated metabolites are excreted in the urine. The elimination half-life is 2.5 hours. Cardiovascular effect: it produces a bit of tachycardia, increase in blood pressure, and increased cardiac output. It is very useful in the shocked, unwell patients. Respiratory effects are minimal, or the minimal effects on respiratory, central respiratory drive. The airway reflexes remain largely preserved, and therefore it's an ideal drug to use in the pre-hospital environment. It however increases salivation, which can lead to upper airway obstruction. So bronchial smooth muscle relaxants, and therefore it is a bronchial smooth muscle relaxant, and therefore has a special role in the management of severe asthma or other bronchospastic reactions. Central nervous system. In the past, ketamine was thought to increase cerebral blood flow and intracranial pressure, thereby limiting its use in patients with a head injury. But providing hyperventilation and hypercapnia avoided, this does not necessarily occur, and there is some evidence that ketamine may have some cerebral protective effects by blocking of NMDA receptors. It is thought to be safe in porphyria. Pharmacokinetics, it is subject to bioexponential decline. The first part is due to distribution, and the second is to hepatic metabolism. It is the least protein bound of the intravenous agents, and about 25%, and it is demethylated to norketamine by P450. Interestingly, the norketamine is about 30% as potent. And the last one that we need to discuss is the old staple, the propofol. So propofol is 2,6-D isopropylphenol. It usually presented as 1 or 2% aqueous emulsion containing soy oil, egg phosphatide, and glycerol. It is isotonic to plasma in this presentation and has a pH which is close to neutral. It can cause pain injection into small veins, but some newer formulations minimize this issue. Uses and doses: induction, maintenance, and sedation. It is very short acting. Onset of action is approximately 30 seconds, and recovery from anesthesia is usually quite rapid. The smooth induction of anesthesia usually follows a dose of 2 to 2.5 milligram per kilogram. Kinetics: it equilibrates rapidly between plasma and brain. Plasma levels decline rapidly as a result of redistribution and prolonged period of hepatic metabolism and renal clearance. The initial redistribution half-life is between 2 to 4 minutes. It is 98% protein bound and has largest volume distribution of 4 liters per kilo. Moderate hepatic or renal impairment doesn't alter its pharmacokinetic, which is important. Cardiovascularly, it produces the most marked fall in blood pressure of all the induction agents. It's mainly due to systemic vasodilatation. There may be an accompanying slight increase in heart rate. The fall in blood pressure is dose dependent and is most marked in the elderly and shocked patients. These can be minimized by slow injections, avoiding inadvertent overdose. With the exception of ketamine, all induction drugs act on the respiratory center to cause respiratory depression. This effect is most profound with propofol, and a period of apnea is usually seen. Propofol also markedly reduces airway and pharyngeal reflexes, making it the ideal drug to use with laryngeal mask airway. Propofol has been associated with epileptiform movements. It must not be confused with true seizure activities, and it is anticonvulsant in normal doses. It has also been shown to reduce cerebral blood flow, metabolic rate, and intracranial pressure. Propofol infusion is contraindicated for IT sedation in children due to concerns regarding its safety. Propofol infusion syndrome has been described, and it's essentially affects children developing metabolic acidosis, lipidemia, and cardiac arrhythmias, and increased mortality. Experience suggests that propofol is safe to use in patients susceptible to porphyria. That's the standard anesthetic textbooks, which I mentioned at the beginning, which you might want to peruse for the details. Thank you very much.